Okay, thank you very much, Asia, and thanks for the organizers for the kind invitation to talk about something that, frankly, I don't do on a daily basis. So I will tell you it is done somewhere else. But I found that the title and the concept, it's quite appealing, is to treat the patient without leaving something behind. And it's been our tradition, interventional cardiologists, to leave almost something behind. It's the case for PCI, for TAVI, for closing the appendage, left atrial appendage closure. And there is also another hope that we can close the appendage without leaving something behind. So this is a very appealing and interesting concept, but we need to have the confirmation of its validity and efficacy. These are my disclosures. So we're talking today about DCB, so drug-coated balloon. What makes a drug-coated balloon? What we need to have that is to have balloon catheter, of course, a highly lipophilic drug, and a coating matrix that regulates local drug delivery to the vessel wall. In contrast to the stent-based technologies, the DCB is able to deliver the drug uniformly to the vessel wall. Paclitaxel has been the drug of choice being used for that particular technology. Sirolimus was also used, but the results with paclitaxel were better just for pharmacokinetics reasons. Now, looking at this slide, it shows all the devices that have been introduced for to be used for PCI, from plain balloon angioplasty to the most recent drug eluting stent. But you see that drug-coated balloons are probably the most recent, or not very much recent, but the most recent devices that have been introduced to be used in around 2005, 2006. And you might not be able to see all what is the rounds below, the circles below, but that represents all the trials that have been used with these devices. Now, in theory, there is a rationale for using a DCB for one admitted indication with this in-stent restenosis. It's the indication where actually now we have a level 1 recommendation. Why DCB is interesting? Again, for in-stent restenosis, because there will be no additional layers of metal, so you don't have one stent in another, which is not a good option. This would decrease the risk of late stent thrombosis. Of course, this would reduce the need for prolonged dual antiplatelet therapy. This will allow repeatability of the procedure. You can do it twice, 3 times. Whenever restenosis recurs, you still can use a balloon and you can treat the patient. Whereas if you have 2 layers of stents, then it would be, more tricky and complex. Of course, there might be potential long-term benefit on hard clinical endpoints, and I will show you a trial that shows actually the use of DCB is interesting in terms of clinical endpoints. Of course, it is a disadvantage, but it's not a disadvantage actually of using this. It's a requirement. What you need to do is to have a careful lesion preparation. And if you don't do that, you would not gain much benefit of using DCB, particularly for in-stent restenosis. This is an important paper published in our intervention in 2022, and it shows the role of DES compared to the other devices, not only in in-stent restenosis, but even in native coronary arteries. And it has actually gone through all the subgroups, from intravascular brachytherapy trials, rotablator trials, drug-eluting stent trials, and native vessels also. So it's a heterogeneous group of patients. What the conclusion of that is DES is superior to brachytherapy for in-stent restenosis particularly. DES with paclitaxel is superior to DES with sirolimus, and is superior to POBA. Now, DES is most likely equivalent to DCB for in-stent restenosis, but remains superior to POBA. This is the trial that I have mentioned a few moments ago. If you remember, a few years ago, there was an information from a trial on peripheral artery disease and the use of paclitaxel stents in the DCB with paclitaxel in peripheral artery disease, and it has shown a frightening information, an increase of mortality. So after that, there was the publication of this very important meta-analysis that is also a heterogeneous one that has compared drug-coated balloons with balloon angioplasty, with bare metal stents, or drug-coated stents. So it's, again, a heterogeneous group, but it has shown important information. It has shown the safety of using this technology with a benefit of all-cause mortality at 3 years, that you can see here, and a benefit of cardiac death also at 3 years. There was no much benefit on TLR, and with regard to MI, a benefit only for the first year. DCB accepted for in-stent restenosis, and this is the algorithm. It's everywhere now. So you have to, if you have a in-stent restenosis after DES, BMS, you have to consider IVUS OCT, and then you see what's the mechanism. If it is an undersized stent, then you have to optimize it. If it's an intimal hyperplasia, then you have to use all the devices, scattering balloon, scoring balloon, atherectomy, whatever. The most important thing, again, is the lesion preparation. If you have less than 30% residual stenosis, then you're allowed to use DCB. Otherwise, you have to go with ADES. Now, the new chapter, DCB for native coronary artery disease. And to date, you know, as I just mentioned, DCB was accepted, widely accepted, only for in-stent restenosis. This indication for de novo is again appealing, but there is no much evidence, and there is few trials. I would mention this trial that was published some time ago. Actually, it's a German non-randomized trials that have compared DCB versus DCB plus BMS, and they have followed the patients for 12 months and then to 36 months. And the results, you can see the bottom line here, where you can see the 3-year MACE, where actually in the first row, there is a superiority of DCB only versus DCB and BMS at 12 months. And the benefit, that advantage, was maintained at 3 years. By the way, the conclusion of that PEPCAD-1 trial was that treatment of small vessel coronary artery disease, because this trial was conducted in patients with small arteries, where actually you cannot place a stent usually. So the conclusion was that treatment of small vessel coronary artery disease with a paclitaxel coated balloon exhibited good 6-month angiographic and 1-year clinical data that persisted during the 3-year follow-up period. But randomized trials, of course, were needed to confirm that, that concept. I would not go back to the rationale of DCB versus DES. Many advantages with regard to antiplatelet therapy, with regard to positive remodeling over time, with regard to local toxicity in the arteries. But let's see what happened in practice. This is a case that's not mine. It's from one of my friends from the Emirates, Dr. Abdallah Shihab, who is known for being the guru of using DCB in many indications, and particularly in this indication that I'm not sure he will do the same thing. But it's maybe interesting to take a look at. 59-year-old male, smoker, hypertensive, non-compliant to medication, important information, presented to the emergency room with crushing chest pain for 6 hours and shortness of breath, and the patient had received the usual treatment. You can see the ST elevation in the anterior leads. This is the coronary angiogram and occluded proximal LAD, left circumflex, free of disease, some kind of disease in the RCA, but not much to mention. The LAD was quite fast, it was opened quite fast, and then a DCB was used, 2.75. You have to be very careful, so using a long inflation, 120 seconds, and went off, and then a bigger balloon with 90 seconds. And the final result, you can see it's very good, although I would see maybe some kind of dissection in that proximal LAD. Anyway, no recurrent chest pain, 24 hours post-PCI. The patient was discharged on ticagrelor and aspirin, and DAPT was modified, and the patient would, for economical reasons, switch to clopidogrel. 4 months later, the patient was admitted with severe dyspnea and chest pain. This is his EKG, cath lab activated, the patient was taken back to the cath lab, and this is what you see, an even better result than the initial one. So there was no occlusion of the LAD, and in fact, it was rather a presentation of heart failure episode than a real recurrence of ischemia. The patient was discharged after 3 days of stabilization of heart failure medication, etc. But what was really important to mention is that the patient has stopped everything. He has stopped all his medications, including antiplatelet therapy. And I would not, of course, recommend to use this technology in order to be able to stop antiplatelet therapy after STEMIs. I don't think it's a good idea. But anyway, just to illustrate that the patient was protected, even he has stopped his medication. And we knew already that he was not very much compliant. So this is the general principle of what we call now DCB only strategy, meaning just balloon. Predilatation, same principle. You have to be really careful with non-compliant balloons, sometimes cutting balloons, scoring balloons. The key issue is to be very careful to don't dissect, to not have severe dissection, and to achieve a less than 30% residual stenosis in order to be able to use DCB. If you have a dissection, type C or to F, or a residual stenosis more than 30%, you have to use a DES with a Loomis drug. So in conclusion, the treatment of de novo CAD using a DCB-only approach has shown promising data so far. Drug elution to a vascular lesion in the absence of a foreign body placement, such as a stent, poses certain advantages over the DES, such as positive remodeling and even greater clinical relevance, a shorter duration of DAPT, favoring the use of this technology, particularly in patients with contraindication to long-term DAPT. Areas where further research should proceed have been identified, and there is a specific need for longer-term randomized trials that compare DCB-only PCI against a second and third generation of DES. DCB-only angioplasty is also beginning to see its use in other challenging interventional scenarios, such as bifurcation, CTO, small vessels, and calcified lesions. Although further evidence for this specific indication is needed, I know that Antonio Colombo is very much in favor of this technology, particularly in patients with diffuse disease. Thank you very much for your attention.